Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, Dr. Paul Nelson Williams. Paul, what the heck is MASLD?
Yeah, it's the specialist ploy to exclude primary care doctors by just making their things harder and harder to say. But MASLD is metabolic associated steatotic liver disease, Matthew, if I am not mistaken.
Yeah, it almost sounds like a pejorative for somebody from Massachusetts,
Almost.
where I lived for almost 10 years. So I love me some people from Massachusetts before the audience gets upset at me. Um, Paul, we talked about a really stripped down way of testing people. You get those mildly elevated liver enzymes. What are some things that we should be testing, and how does alcohol factor in? Talk about that.
Yeah, great question. So I think before you can definitively make your diagnosis through your MASLD, you need to sort of rule out other causes of liver inflammation, things that would cause your transaminases to go up. And alcohol obviously is synergistically harmful with all the things that can actually hurt the liver. So a great place to start is to gauge someone's alcohol intake to make sure that that's not impacting the liver function, not causing hepatic inflammation. And one of the tests that we talked about was this phosphatidyl ethanol test, which we've talked about in other episodes, which is a serologic test to determine chronic heavier alcohol use, I guess is the best way to say that. So it's a new kid on the block. I've seen it mostly ordered by hepatology. It is a way of quantifying, not quantifying it, but a way of determining if someone's had fairly consistent alcohol use up to 4 weeks after the fact, with a cutoff, I think that's cited typically of nanograms per milliliter as a positive test. And the way that Dr. Tapper frames it, and I think most people do, is you're not using this test, Matt, to sort of catch someone in a lie about their alcohol use or anything like that. It's you frame it. This is a test I order for all my patients with liver inflammation. Alcohol is a very common cause of this, and this is just going to help me better understand the factors that might be impacting your liver function. I think is sort of a way to frame that. And then you can have a conversation about that if it comes back positive, and if it does not, then you move on to the next thing. And then, Matt, there's some other fairly common causes of liver inflammation that are relatively easy to address one way or the other. And so, talk us through some of those.
Right. Instead of ordering, ceruloplasmin and and alpha one antitrypsin, all these kind of things, the first thing that Dr. Tapper recommended we do is just check for Hep B, check for Hep C, because we can cure Hep C, and Hep B we can either vaccinate against it, or we need to know it's there and we can treat that as well. We can't cure it yet. So that's pretty easy, right? You're sending a PEth level, you're checking Hep B and Hep C. I think primary care, we can be very comfortable ordering all those things. Now, if somebody has really high ALT levels, like in the 200s, that usually doesn't happen from just steatotic liver disease. So he would, in that case, probably send more of an expanded panel, which might include testing for autoimmune hepatitis, so an ANA, anti-smooth muscle antibody, and IgG levels. But otherwise, most of these patients don't need really crazy testing. But Paul, what's the FIB4 score, and how does that factor into this? And talk about the algorithm that he gave us for staging the liver, is what we'll call it.
Yeah. So you're trying to sort of figure out why the liver is angry in the first place, and then you're also trying to prognosticate about where things are going and how significant the inflammation is and the effect that it's actually having. So your FIB4 is I guess I want to call it a serologic test, but it's a way to sort of calculate how much fibrosis is present based on some common lab tests that we order all the time and you probably actually have in your patient. So it's based on your ALT, AST, the patient age, and a platelet count. And it throws this thing to a formula that I don't know and don't need to, because it's very easily to kind of look up and plug into whatever calculator that you like. And we'll give you a sense of how much fibrosis is present. So if it's a very low score, so if it's a very low score, there's probably not much fibrosis. You can kind of stop there and just sort of do your counseling about lifestyle changes, and which we'll get to in a little bit, and sort of address the reversible factors. If it's above a certain threshold, so if the FIB4 is greater than 1.3 in young adults or greater than 2.0 in older patients, then you need to do a little bit more exploring and actually probably get a more a concrete way to sort of determine how much fibrosis is actually happening. That's typically done through imaging. So there is this elastography that is done. It can be done either with ultrasound or with MRI. I think with ultrasound, is typically what I see done, but Dr. Tapper recommends doing MRI in patients that have a higher body mass index, so BMI greater than 40. Those patients are probably better served by doing MRI to quantify. Again, not using the term quantify, determine the degree of fibrosis that's present in the liver.
Yeah, and that's I mean I think it's like it's very reassuring. Like low Fib4 score, probably doesn't need elastography, and then if it's a higher Fib4 score, you're going to go for elastography. And with the ultrasound based elastography, he gave us this rule of fives. So 5 or less is normal, and then for if it's 10, 40% of those people might have advanced liver disease. If it's 15, likelihood of cirrhosis is high, and then it goes 25, cirrhosis very likely, 25, portal hypertension is likely, to the point where you might even have conversations about starting people on medicine to prevent variceal bleeds, which is crazy to me, Paul. I had no idea that was out there, but I guess we're just moving towards more non-invasive testing and avoiding biopsies. And now, Paul, what can we tell people about diet? Just eat whatever they want? Sugar's good?
Yeah, that's my usual practice. Yeah, just life is short and painful, so just eat whatever you want. No, it's so weight loss is helpful, and you can actually reverse fibrosis with weight loss. Is the takeaway point here? You can actually truly help your liver and bring it closer towards its healthy baseline with weight loss. And I think loss of 7.5% body weight can actually reduce steatohepatitis, and around 10% of body weight loss, you can actually resolve fibrosis, which is really remarkable. And again, it's something that we all know that weight loss can be very therapeutic for lots and lots of conditions. It's just very hard to achieve. And so you, as a primary care doctor, should use what you have in your armamentarium to actually achieve that goal. And so oftentimes that will include certain medications, Matt.
But I like giving people the 10% number, because if they weigh 220 pounds, it's like 22 pounds. If they weigh 300 pounds, it's 30 pounds. And I think most people that weigh 300 pounds think they need to lose 100 pounds to have any sort of health benefit, and it's actually much less than that. So I do find that it helpful in that regard. But even now, Paul, even without weight loss, there's been a new drug that's approved. It's a thyroid mimetic. It's called resmetirom, and it was from the Maestro-NASH trial, Paul, which it sounds like an Eddie Murphy movie. And it's without weight loss, it actually helped to reverse fibrosis. So this, we talked about maybe this is something that is going to be used more and more in the future. It's still being worked out exactly where the place is for that, so much so that Dr. Tapper, as a liver expert, hadn't even had the chance to prescribe it yet. Of course, it was very recently approved. So we will definitely update people on that as we hear more. But lots of great stuff. Dr. Tapper, one of our most celebrated guests. So if people haven't heard him, they should really check out the episode by clicking on the link in the transcript below. And with all that, until next time, I've been Dr. Matthew Frank Watto, and this has been another episode of the Curbsiders, bringing you a little knowledge food for your brain hole.
And as always, our main Dr. Paul Nelson Williams, thank you and goodbye.